Good morning, everyone. Welcome to the Aurora Health Alliance Access to Specialty Care group meeting. My name is Mandy Ashley. I am the Executive Director of the Alliance. So today we are touching on a few things. First, I think we'll do the project mapping, provider mapping project update from HCPF. So Lauren and Devin can provide that update. Then I will provide in conjunction. Vicente, you don't have to do the presentation, but if there are more detailed questions about the ASCENT cohort, we can tag team those together. HCPF provider mapping update.
Yeah, just a quick update and just to provide a little bit of context. I know some of you know about the work that we've previously presented on, but just to bring everyone up to speed, we are working internally at HCPF to really understand our specialty care provider network, which sounds way easier than it is. We are able to easily identify primary care providers, but on the specialty care side, it's a lot more challenging in claims. All the data we look at is either viewed through claims or it's by how providers have enrolled in Medicaid. So we're looking at like taxonomy codes, which is how providers enroll, like it would be like a dermatologist or like a nursing rheumatologist. And there's hundreds of different taxonomies someone can enroll in. So we've been working with our data team who's done a lot of work in this over the past couple of months on trying to group those taxonomies into meaningful specialty care groups so we can actually do something with that data. It's also just challenging depending on where the provider is practicing because their taxonomy might not align with kind of the care that they're actively providing. That being said, we've also, through this process, we've consulted with our clinical team quite a bunch on just understanding how do we want to identify these providers? Are we looking at just specialty care providers that are MDs with kind of specific like experience within certain specialty care areas? Are we looking at more advanced practice providers, you know, PAs, NPs that are also doing this work? So that added another kind of layer to this data where we're trying to also differentiate between both of those groupings. So it's just been a continual kind of iterative process. I feel really excited about where we are with it. This has not very cleanly been done at the department at HCPF for some time. So we're working through that. I will also share that hoping this year to do some collaborative work with our partners at CU to understand more specific zip code data around the Anschutz Medical Campus and in Aurora. So pulling out some zip codes because it's also really hard to dive into the data when we're looking at all claims data across all of the state. So we're starting to really zone in and understand our methodology for looking at specialty care access within Aurora. So hoping this year to work through that with CU and hoping maybe to have some outcomes we can share with this group towards the end of the fiscal year, which is in June. And I'll also share that through our process with the eConsult platform that we're moving towards, a statewide platform, we're also hoping because we'll be enrolling providers within certain specialty care areas, this might add another layer of cleaner data into our system on how providers are enrolling in the eConsult platform. So we can, again, have cleaner data to understand who our specialty care providers are and where they're providing specialty care. So a lot of different pieces of data that we're working through at the department and trying to clean up. Very optimistic that this year will get to a good place. And can continually just, you know, share updates as we move along in that process with this group. And as always, if there's ever any questions or specifics around that, please feel free to reach out to myself or Lauren Phillips, who's also on this call.
And so real quick, Devin, you mentioned June. So you think by June you will have something that primary care providers would be able to use, or would it just be internal to HCPF?
So we're definitely, yeah, I know I just threw out a lot of different projects at you all, but so the first one being hoping to have a provider tool that we can share and hopefully have more updated provider information, even on our website, or ways that we can share with the RAISE. So definitely an external facing tool, which might just be a list, but a tool. I forgot to mention one of the areas that we're also looking at is having an updated list that looks at providers are actively billing Medicaid. So we know some of our lists possibly outdated, or some providers that are not seeing Medicaid. So hoping to build that into this tool as well. The comment in June is more along our specific kind of Aurora analysis in those specific zip codes. We'll know more in the upcoming months on what that scope of work and analysis looks like, but happy to keep this group in the know.
Thank you, Devin. And I just wanted to, we have a couple of hands raised and I'll get to those. I just wanted to thank you for working so closely with us on this. I know I feel seen as the Alliance working with you, and I know that our feedback is heard through you attending our meetings and things like that. The first hand that I saw was Maisha's.
Thank you. Thank you for the presentation. I was wondering, I recently got a letter from Dora, specifically as a nurse practitioner. They have been doing a series for probably about the last 3 years to understand where nurse practitioners are practicing and what is our scope of practice where we are practicing. And it's about a 2-page questionnaire. It's also a part of like our re-credentialing process. That you are required to fill out this information. And a lot of it also addresses some specialty care questions. And so I was wondering if you all have had an opportunity to connect and talk to Dora about your project around specialty care amongst physicians, because that may be a good way to implement some of the things that they've been doing to measure nurses and nurse practitioners. And nurse practitioners even in the mental and behavioral health sector as well.
Thank you so much for bringing that up. I was not aware of any collaboration we have, but I will connect with our, we have another office in HCPF, and they do a lot of our like provider kind of outreach and enrollment. We're working with them on kind of defining these specialty care categories. So I'll touch base with them to see if they have made that connection, and if not, definitely appreciate the input, because I think we will definitely be reaching out if there's no connection made. So thank you.
Yes, thank you for the work you're doing.
Thanks, Maisha. Dee Dee?
Yeah, hi. I'm not sure if this question makes sense, but I'm wondering like how this intersects with Ray's and Ray work and their sort of capacity around network adequacy around specialty care and that whole piece.
Yeah, that's a great question. I think 2 months back, I'm not sure, over the summer, Lauren and I did present this to the Rays that we're working internally to figure out specialty care better. Each Ray does something a little differently when they're tracking specialty care, but hoping that through this process internally at HCPF, we can kind of come to an understanding internally, but then start sharing that out with our partners and aligning across the Rays. So I definitely think there will be alignment happening and collaboration in that space. So thanks for bringing that up.
And can I add just one more thing going forward? Sorry. Also, how this might intersect with or what it means for ACC 3.0 and the Ray contracts and network adequacy as well.
Another amazing question. Yeah, a lot of conversations in that space. We pass along kind of what the areas that we're working in with access to care to those groups that are doing more of that exploratory kind of development work for the ACC 3.0. But happy as developments occur in that area or questions come up, again, happy to bring that back to this group.
I wanted to speak on behalf of Colorado Access that we are always working on ways to identify the specialties that are of greatest need for our PCMPs to be able to refer their patients. As you guys know, it's a constant problem and challenge, because one day we may have a dermatologist say, yes, my panel is open, and the next day it closes. And so that is something that we constantly are working on. We pull claims reports to find out who hasn't submitted a claim within a certain amount of time. We give them a call, is your panel open or closed? We work really closely with our care managers to see what specialties they are needing. But because we're behavioral health Medicaid as well, we do a lot of work around the behavioral health subspecialties as well. And George is real instrumental in providing augmented services to that. But I think the most important message needs to be that this is work that never ends. And, you know, I've been in healthcare for 30 years, and this has always been the biggest problem is access to specialty care. And how do we define that? And previously we didn't have data, and, you know, for years we do now, but it's still not great. And it's still not easy to keep up with the providers if their business model is, I'll only take a percentage of Medicaid. If they reach that percentage, they close their panel again, then they open it again, then they close it again. That's where we really struggle with being able to keep up with them.
Yeah, thanks for your thoughts on that. I agree. It's a continual challenge, so continual work is needed. And I also think there's not one solution to access to care, and definitely exploring ways throughout the state on like how does telehealth fit in, and not just telemedicine, but e-consults, other innovative ways to kind of get patients to access specialty care in a quicker manner than the traditional face-to-face, and looking at some of those referral pathways, which I think we're even talking about later at this meeting. So thinking about what that looks like and knowing that there isn't just one answer to improving specialty care access.
Sarani, I think your hand went up next.
Thank you. Devin, you may have mentioned this in a previous meeting, but I'm wondering, are you also tracking on the provider taxonomy codes, oral health providers? I'm just especially curious because there's a new dental KPI that the Rays are going to be working on later, and they include the whole long list. So I'm wondering, are you tracking dental? And if so, how are you working closely with the provider outreach and enrollment that you're talking about so that it can ultimately help the members in finding providers themselves, and you find a provider tool that you have?
Yeah, I think, I'm not sure if it was you in a previous meeting or someone else, but I think we had that comment at maybe our last quarterly meeting. And so we did add that in to our list for this provider tracking for oral health care. I'm not sure if where on the radar it lives with our provider outreach and enrollment team, but I can definitely follow up. It's not an area that's come up since we've mainly focused on specialty care, but definitely an important area that I'm sure is on their radar somewhere, but how it's integrated into this, I can explore a little bit more.
Great, thank you.
Heather.
Well, first, I just wanted to thank you for having community engagement as a part of your strategy for getting feedback and developing the tool. And we appreciate you coming to these meetings and hearing what we would like to have included in that. It's just helpful to have that kind of partnership with HCPF and know that you're hearing, what would be of most value, not just for organizations, but ultimately for Medicaid members in the community. I remember you mentioning that you're hoping that this would be active providers that are billing under Medicaid. Can you remind me how you're determining active? Is that if they've had a Medicaid claim in the last year, what's the time frame you're looking at for that?
Our initial build with the tool was just in the last year. However, that's extremely flexible if we wanted to update that or change that. I think it'll also depend on how we externally share this information. So it all depends how we'll share it. If it needs to be updated on, providers within the last month, which might be a little challenging with our claims run out. But if it made more sense to do it every 6 months or quarterly, that would be super easy, but open to whatever the group would find helpful too, but knowing that it'll probably depend on how this is used and how this is shared.
Yeah, considering that the list like this doesn't currently exist, I think people are excited and welcome to anything, but to what Anne was sharing, to have something that's updated because it does fluctuate and change so much, over the course of the year. Panels can be open for taking new Medicaid members for specialty care, but then it changes. So being able to have some flexibility on the frequency of when that is run will be really helpful as well. Thanks.
Awesome. Thanks for your comments. And Lauren, am I missing anything or anything else from the HCPF side on specialty? I know we have a lot of moving pieces right now.
No, I think you covered it. And I'm going to echo what Devin said. If there's anything that comes up, in the middle of the night, you're thinking of it, please reach out, because this is an iterative process. It's forever moving forward and changing. So we want to make it work for everyone. So just keep us in the loop, and I personally don't know anything about when panels open and close and how that works. And so hearing more about that of when we'll capture that data correctly, when they're having those claims where we can utilize that list would be helpful too on our end, just to understand that and make sure the data works for providers.
Well, and I think the hardest part is we don't find out they've closed until we've referred members to them. And that's when we find out. And so that's why we're having to be much more proactive, but it's a huge lift because it requires a personal phone call.
One other question, we can't be the only state facing this problem. So what do other states do, or what are other strategies, both to track provider lists, but also to persuade, require specialists to accept Medicaid patients?
Great question. We do have a kind of our network of Medicaid agencies, a collaborative that we work with. So we could see if there's been anything previously identified within those groups, and then we can always take that to our cohort to see if we can learn more.
I mean, just looking at research, it doesn't feel like anyone has cracked this nut. Maybe we'll be the first, right? And just thinking, Dee Dee, to your point, like thinking ahead to ACC 3.0, how can we be a voice in that around this issue? Because, we'll start to give feedback. There'll be community feedback opportunities and PCMP member opportunities for feedback. So I think that's something that we have the opportunity to be vocal about as that model's developed.
So I was thinking about, what ways that other industries have really done a good job of cracking this nut. And I'm thinking about behavioral health therapists and our mental health providers. Oftentimes our navigators are trying to, make people appointments. And as soon as they go to their website, they'll say not accepting new patients. And that's just not for Medicaid. That's just no patients at all. And I'm also thinking about website platforms like Indeed and LinkedIn, where you can automatically go online and say, are you looking for a job? Are you interested in these types of opportunities? So I like the idea of someone saying earlier, how do we encourage providers to self-report? Because it also takes time away from them for their staff to answer the phone and just to say, no, we're not accepting new patients. So it would be really interesting to see if there is a policy that would strongly encourage and incentivize providers to declare, are they accepting Medicaid, and are they and what type of specialty services do they provide?
Yeah, it feels like in this day and age, we have the technology that that should be available. I know historically in our kind of provider search tool, we had an option that was accepting new Medicaid members. I know it was not correct, but I can also dig in a little bit, maybe to see what our process was in previous years on identifying that, if there was some type of outreach occurring and maybe that stopped. Just knowing that, we have the technology where no one's using the technology to the advantage of being able to do something like this. But yeah, a really great idea.
I can tell you,
I'm loving the feel of this brain trust this morning. This is great. Go ahead, Sirini.
I was just going to say, I can tell you on the oral health side, similar to what was mentioned on the physical health side, it is a never-ending challenge to be able to maintain this type of data. And we always try to provide a stopgap with our network managers who are contacting providers who say they no longer want to accept Medicaid, to try and encourage them to stay part of the network. So making it easier for them would alleviate a lot of problems on the one end, but then I think it would also make it more challenging on the other hand, because then I think it just, the fluctuations in the network make it challenging. So I'm with you, Devin. Technology is there, but you also have to have the human touch to try and encourage them to stay within the network too.
Okay, so the next item on our agenda was just an overview of the ASCENT cohorts recommendations. So There are a lot of slides. I am not the author of these slides, but I'm presenting on them. Are you seeing the cohort membership now?
Yes.
Awesome. So the cohort members are listed here. I just wanted to note that thanks to the Mile High Health Alliance, the Aurora Health Alliance, and BCHIC, the Boulder County Health Improvement Collaborative, were looped into this work. We had originally applied, but were not included in the original group, but we are thrilled to eventually be looped in. So ASCENT was intended to address Colorado's urgent specialty care needs through multi-pronged approach, including e-consults, referrals, best practices, and systems change. The main discussion item that I experienced after the Aurora Health Alliance was looped in was about e-consults. We all know what e-consults is because we have talked about them in this group on repeat, but here is a reminder on screen for those who need it. And just wanted to note that the upstream approach can reduce demand for specialty care visits in person by taking care of those needs from provider to provider. The cohort members worked on referrals and shared best practices, lessons learned both during cohort meetings, but also offline with one another as well. I refuse to read at people, so. And then the last item is systems change. This included reducing barriers, trying to reduce barriers to specialty care access by changing systems. Here's a visual of the logic model here. So if you start in the top left, the patient specialty care needs, then if you leverage the cohort's expertise in specialty care access by using all of the strategies that I just spoke about, you have short-term outcomes for increased access to specialty care for patients, the listed ones for the system, including increased reimbursement, and then that'll hopefully leads to the long-term outcomes of improved health, lower costs, better quality. All of this is going to be included in the final results section and a final PDF presentation that will be shared with all of you. So keeping time in mind, I'm going to click through some of these, but the ASCENT cohort is complete now, though we will still be meeting hopefully on a quarterly basis just to stay in connection with one another. So the final results of this effort: increased referrals. Over 40% of those were for Health First Colorado members, and almost 50% were for uninsured patients. In period 7, which was on the next slide, over 80% of face-to-face visits were completed within a month. So that is a reduction in wait times. The e-consults and referrals helped increase access to specialty care. The dark color on these bars is face-to-face, and the lighter color is e-consults. The completion of rates of referrals increased over time, which is positive. Again, we can go into detail about this at a later meeting, or there will be detail in the more detailed report that I'm sending out after this meeting. e-consult referral trends reversed at the end of the pilot. So if you don't like fast clicking, look away for about 5 seconds. I'm going to click to the recommendations of this slide deck. So recommendations, e-consult program pillars of success. There are 4 of them. Provide program and network coordination. Secondly, establish practice champions. Third, offer patient navigation. And fourth, promote equity-driven workforce development. And these were all presented to HCPF. Recommendations continued. An interoperable network requires relationship network. Those equity-driven practices, there's a little bit more detail in there and in the report. Expand the impact of e-consult network through integration with other systems and community resources. Recommendations on evaluation and accountability are listed here. Consider both macro and micro level evaluation and accountability, which touches on individual and family, providers, and systems. So there's a lot that this cohort attacked, I guess, worked on, considered. Here's a picture of, oh, the good old days when people were right next to each other unmasked. And then here's some more detailed contact information. Vicente, I went through that quickly. Is there anything that you want to highlight with this? Or our Kaiser friends on the phone?
No, obviously there's a lot that was said over here, but just kind of like what's next. I guess that's kind of main thing here. Obviously the ASCENT cohort has finished, and it's bittersweet, but one of the things that came out of it was that the relationships that were built during this cohort was really strong, and felt that the best next steps were to kind of still continue to do the good work, right? Because as we've already heard previously, specialty care access is still an issue. And so right now, what we're really trying to continue to assist with is kind of HCPF's e-consult platform. And so unfortunately, we don't really know who the vendor is that they have chosen, but unfortunately, we'll have to figure that out till the beginning, or we'll wait till the beginning of 2023. But right now, HCPF has a e-consult team that's really focusing on this platform, and has reached out to both CHI and Mile High Health Alliance, and really having these kind of in-depth conversations and providing these recommendations. And so one of the main things that we're really looking into is more of the evaluation portion, and how can we make sure that, one, we emphasize kind of like the interoperabilities, how do we make it seamless? How do you address the in-person visits when you're making these e-consults? And really just kind of focusing on that big main question: how are you going to get these specialists? Because if you can't, you can make the perfect system, but if there's not enough specialists to meet the need, it really kind of makes it a little troublesome. And so what we're trying to do is kind of still kind of keep these conversations going, and look to kind of host kind of not like several quarterly meetings to kind of continue to share these best practices, see if there's any individuals who have any openings within their own networks, provide updates about the eConsult platform, and actually just grow collectively so that we can provide not only just recommendations, but just to have kind of like more voices of the community to say, hey, this is what we've been talking about, and this is what we want to advocate for. And so those are kind of like the next steps that we've kind of taken as the ASCENT cohort. And granted, yes, there's a lot of information that has happened with the ASCENT group, but as Mandy said, if you want, she'll send all the details, and you can reach out to me personally afterwards to kind of talk more in depth on the data. But yeah, that's kind of like next steps on that. And if you guys want to be a part of that conversation, or want to, just be, share your stories on specialty care, we're trying to look to kind of grow this as big as possible. So yeah, I think that's it for me, Mandy.
Thank you. So if there are folks that are focusing in on eConsults and want to provide feedback, advocate a little bit, that would be through this quarterly meeting that Vicente is convening. The Access to Specialty Care interest group will, for Aurora Health Alliance, will continue to meet around the things that we have been meeting about. But if you want to focus in on eConsults and providing active feedback, that'll be through the ASCENT cohort. So reach out to me or Vicente if you want to be included in that. Any questions?
Sorry, I had a question.
Go ahead.
I couldn't see the slide where it talked about the specialties. It showed which specialties were among the highest utilizers. I was just curious to see what that looked like. We do a lot of behavioral health, so I do eConsults to behavioral health, but there's issues around that because I always want to turn into referrals. There's only so much you can do. I don't think I saw behavioral health up there, but I was curious to see, or maybe Vicente, if you just wanted to tell me, like, what were those high utilizers of the specialties? Oh, there you go. Yeah, okay,
So
those are
there's
the ones that make sense.
several of these. So the top specialties for referrals as found by this group are listed here. So no behavioral health.
Yeah, I didn't think so. And just the other thing I was going to say really quickly is because I work really closely with primary care practices. So when you talked about, like, they talked about like having a champion, communication, like these are all hard lessons that I've learned as well. This is the super hard way by working through primary care. But yeah, having that champion and taking the time to communicate that with them, that's key, because one of the things that I've learned working with primary care over the last few years very intensely is really how the pandemic has affected them and how there's so much change and turnover that's going on with primary care. It's hard to coordinate trainings. People leave, they don't always let you know. Maybe things that you train people on, Vicente, maybe you're learning some of this as well, right? They don't always let you know when people leave a practice. You have to retrain people, and they're not just dealing with one insurance, they're dealing with many insurances as well. So it can be challenging, but thanks. I was just curious because yeah, we've had issues. We do e-consults for behavioral health, but it turns out that most of the time they turn into referrals. So I was just curious to see how the specialty care worked out. Thank you.
Yeah, no, with the behavioral health, I know that was a little bit different because it's a different payment model. So I think we didn't really specifically focus too much on behavioral health. But to your point, in terms of the education, I think that's why one of the pillars in which we're trying to advocate for is for that patient navigator to be like, hey, this is how, here's how to word things a little bit differently. Here's how, we can train people on how to kind of communicate with physicians and specialists. And so finding that like middle person to kind of really kind of advocate and educate along this process, because as you mentioned before, the pandemic has really kind of exasperated a lot of people, and just kind of like we want to make things as easy and educate people along the way, because this is going to be another change and another ask for providers, and sometimes that's not what they're looking for.
Thank you. Yeah, very true.
Dee Dee?
Yeah, hi. I agree 100%. Like, I think what we're talking about is disrupting workflow, and that's always problematic. The change management piece because of COVID, and the champions are great, but if we don't institutionalize, we end up with the sort of problems that we've been talking about, right? Somehow it's got to be structurally built in, and that takes time. And I would just also, we talk about patient and care navigators a lot, but there's sort of clinical worker navigation and care, right? There's just a lot of support they need to adopt new systems and to, anyway, that's all. We've seen it across the board, not just in specialty care. We've seen it in our medical legal partnership screening, across the board. People are tired. There's been a lot of change, and it's really hard to institutionalize new processes and workflows.
Heather?
Vicente, you mentioned that there's going to be a group that's going to continue to meet around this. I think you said it was quarterly. Can you talk a little bit more about what that group will be focused in on and what you're hoping to accomplish?
Yeah, actually, I think we're trying to have a kind of like a preliminary meeting to actually kind of figure this out. But really what it is after kind of our last day at the ASCENT group, we kind of asked whether or not we still want to keep in contact and really continue these conversations. And what we found was a lot of the primary clinics who don't really engage on the policy aspect really wanted to kind of keep tabs and see what's going on. And they found a lot of the information that we provided useful. So what we're trying to do is kind of have the first preliminary meeting and say, hey, you know what? What's going to be the best way to share best practices? What are we trying to accomplish from this meeting? And kind of, if it's solely on recommendations, like how can we make it more impactful? So I think that's kind of the main goal of that. But I think really what a lot of people were excited for was the sharing of best practices and understanding what's going on like a systems level, because a lot of people on the ground just don't have the time and capacity to really kind of dive deep in there. So I think that's kind of like the main kind of direction we're going towards this group, but that's why we want to have this preliminary talk and really kind of break things down and make sure we have an agenda, because we don't want to have a meeting just for the sake of a meeting.
Gotcha. Thank you.
Otherwise, have a great holiday weekend. Happy September.